Hello class, just a little bit of advanced notification here. As a reminder, the midterm exam will be week 5. It will be a multiple choice exam given on Blackboard. The topics being covered are going to be Gonstead history, Gonstead analysis, the acute lower back, facet and spondylo, and all of the lab material, which includes side posture with all of its setups, knee chest table with its setups, acute lower back protocol, your listings, lines of correction, segmental contact points. All this is material that's eligible for the midterm exam. What we have here is a slide I typically ask in our live lecture class. How well prepared do you feel with managing a patient with acute lower back? As you can see below the choices, so just answer this question to yourself and contemplate how well you feel prepared to take care of a acute lower back situation. And the rest of today's presentation will cover how Gonstead approaches acute lower back. Today's lecture is going to cover the management of the subluxation in a patient with an acute lower back. And a lot of techniques have a process to do this, but we're going to really be doing this Gonstead style. Have you taken care of a patient with an acute lower back? Yes or no? The following is a case scenario we're going to be using to answer a series of questions after you complete this. Take a moment to read this slide, to review the details of this case, and we'll be asking a few questions pertaining to this case and how to manage it on the next few slides. Would you accept this patient for chiropractic care? If you say yes, the next few questions will ask how you're going to take care of that patient. If you say no, think of those reasons why you would not accept this patient at this time for chiropractic care. If you were to accept this patient for chiropractic care, what are you going to do with him? Any technique you want you can use to answer this question. Now, since we're in Gonstead class, and if you were answering this in class with the survey and the clicker, you would be smart to be nice to your professor and answer D for Gonstead. But that's not the case. You're welcome to use any technique that you wish here. But when you're thinking of what technique you want to use, hopefully one that addresses acute lower back issues. If you have this patient under your care, how long will it take? Do you predict it will take to see progress with his condition? 3 days, 1 week, 2 weeks, 3 weeks, or 4 weeks? These are things we need to consider when making or predicting a prognosis with our patient, and today's lesson will cover some of the ways we can make these predictions. For those of you who choose no referral, you're welcome to continue caring for your patient, but when the patient's not making progress, you need to consider other options or other avenues of care since your approach to chiropractic care is not working. Referring to another chiropractor is a very good choice if this patient is not in need of emergency care or emergent care from another practitioner. Another chiropractor who may be more experienced and better skilled than you are may be a better choice for taking care of this patient at this time. You can't let your ego get in the way of taking care of this patient. It's often nice to have another professional look in on your case to see if they have a different perspective and how you can benefit this patient. You could, of course, refer this patient to the medical doctor and see what they have to say, bring them in on the case. You may want to refer to the neurologist, but this is not typically a neurologist type referral because neurologists deal with things that are problems with the nervous system, not necessarily acute situations. The neurosurgeon may be a good referral because neurosurgeons at this point, based on the patient's presentation and pain, we're assuming that they have a very serious issue going on that may require surgical intervention. So they would probably be the person more than likely you would be referring the patient to. But before you get them to the neurosurgeon, the first question they're going to ask when you make that referral, if you make a direct referral to the neurosurgeon's office, they're going to ask if the patient has an MRI because the neurosurgeon won't even look at them until they have that advanced imaging. So your first choice may be the MRI before they go to the neurosurgeon. Okay, the antalgic lean versus the position of the disc lesion. You are familiar with these before. You've had these covered in other classes. When we have the lateral disc protrusion, the patient leans away from the disc lesion to the opposite side. So if it's a left disc protrusion that's lateral, the patient will lean antalgic to the right. If it's a medial disc protrusion, the patient typically leans to the same side of the protrusion to keep the pressure off the nerve. Okay, here it is again, describing the type of disc lesion and how the patient will lean according to that, what their antalgia will be. We already discussed the lateral disc lesion and the medial disc lesion. Subarachnoid disc lesion is typically described as a lesion or a disc protrusion that goes directly at the nerve. Okay, and that patient may lean forward or not at all because it's very unusual. One, it's an unusual situation, and two, the body doesn't know which way to go, so it may not do anything at all. The central disc lesion is the most complex one to deal with and manage with the patient because they may have bilateral pain. They also may have pain that causes them to switch sides for their antalgic position. This one can be a little tricky at times. Why is it important to know what type of disc lesion you had? Because that will give us some information in determining how long it may take this patient to respond to our care and see the symptoms subside. Okay, the disc healing timetable. What this does is it allows us to give a prediction on how long it will be for that disc lesion to show results with chiropractic care and the patient start getting out of their antalgia and on their way to healing. The lateral disc lesion, approximately 2 weeks. Medial disc lesion, 4 weeks. The subarachnoid, 4 to 6 weeks. The central, 6 weeks. So if you have difficulty in trying to make sense of this, as we move from lateral to medial, it seems to take longer for the patient to respond, be out of antalgia and pain. So from lateral to medial or central, it takes longer. And like I said earlier, the central one seems to be the trickiest one to get to respond, and it takes the longest for the patient to respond to it. Okay, our physical examination is an important part of our visit with the patient here. I'm going to try to bring all of this slide up here. I forgot it was in parts. Okay, so we want to take our history. As we discussed in the lecture on spinal analysis, we want to know what happened. We want to know if there was a mechanism. We want to know if the patient's had this before. We want to know our OPQ-RST for this. Typically, in an acute lower back situation, that onset is rapid. It's a pretty sharp onset, not typically a gradual onset, often with radiating pain, and it can be made worse by any number of movements or positions by the patient, depending on the disc lesion, how severe it is, and where it's located. Our ortho and neuro exam are very important in this situation because it may help us really confirm if it is disc involvement or not, or if the nerve root is being compromised. Valsalvas and Desjardins are very important, typically will be positive. Straight leg razor, positive at 45 degrees, although if it's a very severe disc protrusion, putting a lot of pressure on that nerve root, that straight leg razor may be positive long before 45 degrees. Your neurological package, your motor, your sensory, and your reflex often have some positive findings when you have the acute lower back situation. Sometimes you may have only one component of the neuro package that's positive. I had had patients with just the motor function that was positive in the neuro package where there was a deficiency. I have other patients where it was just the reflex in the neuro package that was positive with no other positives in that testing. So it may be one, all, or just, maybe part of the package that's positive, not the entire package. And also what is not part of your neurological package, but you can use to help correlate which disc or root level, a nerve root level might be affected, is your pain pattern correlation. Remember, it's not part of the neuro package, but you can correlate that with the nerve root and perhaps predict which disc is involved. Again, I'm going to bring all the components of this slide up so we can discuss them. Okay. Our chiropractic exam, after we've done our ortho, neuro, and physical exam, we go right into our Gonstead chiropractic exam. We use our instrumentation. The sympathetic reaction to pain may be inconclusive, but the scope also may be inconclusive because there is typically a lot of heat brought to this area because of the injury to the disc. a lot of inflammation or edema there, may decrease the scope reading, but we still do attempt to find our break reading there. Static palpation, there'll be a lot of fluid and muscle guarding and spasms. This will be covered in lab in week 2. Motion palpation may be difficult to perform, but we still do. We're still trying to see if there is a fixated segment. Percussion and vibration may be positive on the spinous of the involved segment. And Gonstead, as in all of our patients, we do our x-rays, our A to P full spine 14x36 and our lateral 14x36 film. You may perform the standing lumbar regionals only if the patient antalgia has them leaned over too far to get them in the view of the full spine film. What we'll do later is we'll take our full spine films after the patient's antalgia has subsided and they're standing up to their normal posture. I've only had to do this a few times in my practice where the patient was so antalgic we could not get them to lean up far enough to fit them on the film, or their antalgia was so far anterior as we couldn't get them to stand up straight enough to get the view we needed. So we only ended up taking a lateral lumbar view so I could see which disc was involved, and we worked on determining listing from the patient examination. Okay, in Gonstead, we learned again in lab what the presentation of the disc will be. What we'll have is what we call a D1 disc, where the parallel end plates will be seen. Instead of being narrow at the posterior aspect of the disc will appear a little bit enlarged, and the end plates between the vertebrae above and the vertebrae below will be parallel. That is a D1 disc. What you see here are 2 films. The one on the left, the presentation is what appears typically on a normal lumbar curve, where the discs are slightly narrow at the posterior aspect, helping contribute to the normal lumbar lordosis. The X-ray on the right shows that the L5-S1 disc is swollen and the end plates are parallel. And this is the typical presentation of a D1 disc with a patient with acute lower back. Management of our chiropractic patient with acute lower back. As you know already from lab, we ice over the area of the affected disc for 20 minutes. This is for an analgesic effect and to help decrease the edema and inflammation in the area. Next, we bring the patient over to the high-low table. We place them prone on the high-low table, and we adjust or manipulate the high-low table to accommodate the patient's antalgic position, because the antalgic position was comfortable for the patient. If we just lay them on a flat table, that's forcing them into full lumbar, normal position or extension there. It's not very comfortable for the patient, so we will adjust the table to accommodate the patient. We are going to pump the vertebrae of the involved disc. So if it is the L5-S1 disc, we're going to pump L5. We're going to pump this disc to improve the movement in that segment and to work some of the fluid out of the disc. We'll keep doing this pumping until the motion or movement increases in that disc and the patient can tolerate this pumping well enough to prepare them for the adjustment. The third part of this protocol is adjusting the patient after we complete the icing and the pumping. We're going to adjust this patient with a side posture pull move to make the correction, and we're going to do this on the segment below the affected disc. The pull move is used because it can be a little bit faster than the push move, so that the patient will not guard us as much because we can get the adjustment in before they fully guard against the adjustment. Also, it allows me to keep the patient in a more neutral position. I roll them over or roll them in a little bit less when doing this adjustment. And the purpose of this adjustment is not to get that home run adjustment, adjust them as hard as you can, but to get movement in the segment when we do the adjustment. We may often not get an audible because the amount of edema and fluid or inflammation even in the facet joints, if it was an acute injury that brought on the disc injury, a trauma. So there might be a lot of inflammation and swelling inside the joint, so we often do not get an audible, but we definitely want to try to feel the movement when we do that adjustment. What you see here is a diagram where we're going to pump the vertebrae above the involved disc, and then we'll adjust the vertebrae below. So in this picture, it's the lowest lumbar will be pumping, and the sacrum will be adjusting side posture. And yes, you can adjust sacrum side posture with the pull move, contacting S2 just like we would for a BP with our fingertip contact and a pull stabilization, and we adjust that P to A and S to I. This is a graph trying to give a representation of how the pumping works. Their force is on the vertical graph and time is on the horizontal graph. Force in this case increases as we go down from the top there, and time increases from left to right. What this graph is demonstrating is that each time we're depressing the patient going P to A, we hold the pressure, just let the patient breathe, and then we push down a little bit more so we can increase the pressure with each subsequent breath. Now, depending on how acute the patient is or how well they can tolerate this timeline may not be exact here, which shows, it's a 10-minute timeline on this graph showing 5 minutes of pumping. I've never done 5 minutes straight of pumping, but I do let my time be dictated by how well the patient can tolerate it. The patient's tolerance will also dictate how deep I'm going with that pumping. If I reach a depth of the pumping and the patient can only tolerate a certain depth, I may continue pumping at that depth instead of trying to increase the pressure or the depth with that pumping. It all depends on the patient's tolerance to the pumping. It's always adapted for the patient, but the goal is to try to get as much movement as you can in that area. Try to get that pumping as deep as you can to help prepare them for that adjustment and work the fluid out of the disc. Okay, the care plan for this patient we see twice a day in the AM and the PM, at least 6 hours apart. Gonstead said that it takes about 6 hours for the body to make its adaptive changes, especially when working on edema and moving fluid in and out of the area. See them twice a day until the symptoms are noticeably improved or their antalgia is reduced or gone. We need to be very intensive with this care at this time. Now, on each of those visits, when I see them twice a day, it doesn't necessarily mean I have to adjust them each visit. If they can't tolerate it, maybe I'm pumping them one visit and adjusting them on the other. Typically, when we're seeing these patients, if we're seeing them 6 hours apart, especially if one is in the morning, one is in the afternoon, because they've been up on weight bearing and gravity's been working on that disc, it tends to push some of the fluid out of the disc. So they tend to be more accepting and tolerant to an adjustment in the second or PM adjustment. But as they progress, they may be accepting the adjustment for both of those visits in the day. But typically, better chance of getting that adjustment done in the PM visit as more fluid is worked out of the disc from nature, just gravity pushing on that disc. For their home instructions, we instruct the patient to ice 20 minutes every hour. We instruct the patients to be walking at least 5 minutes each hour, and that's a minimum. As the patient starts to improve or the patient can handle it, I want them to be up, moving, weight bearing as much as they can. I want that disc to have weight bearing on it. I want the body to be moving. I want fluid to be moving in and out of that disc, and more of it will be moving out, of course, because it's on gravity. When the patient's sleeping at night, they're not weight bearing on that disc, so the disc tends to suck up or pull in more fluid. So in the AM, they'll be much stiffer than they will as they're up and moving throughout the day. That's why the adjustment in the PM typically is where we get the better adjustment or better opportunity to adjust them. I also instruct the patient to do mild stretching for the lower back. That may include cat-cow exercises. They could either do those on all fours, or if they can stand, they can lean over and put their hands on a table or a bed or a chair, and they could do that arching motion, arching up and then going into extension. What this does, it simulates the pumping of the disc with that cat-cow exercise with a little flexion extension of the lumbar spine. I also instruct them they can do side bends, trying to bring their shoulder towards their hip. So they're also pumping a little bit laterally by kind of wiggling their shoulder down towards their pelvis and back and forth, little lateral flexion exercises. They can do this on all fours, or again, just bent over with their hands on an object for support and allow some movement there. And I really don't want the patient to be sitting much. Sitting just almost forces the back into a flexion position unless they're sitting very upright with a lumbar support. I want them up and I want them moving. Being in a static position just isn't good. I want them up and moving as much as they can. They can lay down for a period of time, especially if they're very, very acute. They need some time to recover and rest, but try to avoid sitting. Okay, follow-up care with this patient. As the patient improves, we'll back off the care to 1 visit per day. typically in the afternoon or evening. Like I was explaining earlier, that disc typically will draw more fluid in the morning or at night when they're at rest and not weight bearing. I want them to be up, moving, get some of the fluid worked out of that disc from weight bearing, and I want to see them in the afternoon or evening. Much better chance of us getting the proper adjustment done at that time. And then as the patient progresses, we continue to decrease the frequency as the patient improves. I'm not the type of doctor, nor does this patient need that 3 times a week for 12 weeks, even after they are out of the acute situation. That body needs time to adapt and recover. And a rule of thumb is after the patient's out of their antalgia, or even before they're out of their antalgia, if they come in for one visit and they have noticeably marked improvement in their symptomatology and antalgia, that may be a visit where I examine the patient, determine what's going on, but they say they have significant improvement. Maybe the radiation of the pain's diminished, their antalgia's diminished, their pain's diminished. That may be a visit that I do not adjust. It is okay to give them more rest and more time to recover. That is better than trying to over-adjust them, because if you adjust them when they're on the upswing or a pretty significant upswing from between 2 visits, we could actually over-adjust them and send them backwards. And I know this by experience. It's one of the rules of thumb in Gonstead. If the patient shows significant improvement from visit to visit, that there may be a visit where we let them go, let the body continue improving and adapting instead of over-adjusting them, because if we give them that one adjustment too many, we risk sending them backwards in their symptomatology. So there's no harm in letting them go for the day, letting the body recover and adapt and heal, than over-adjusting. So keep that in mind. Also, as the patient's symptoms subside and they're restored to normal posture, we do re-x-ray our patient, because now we have to continue with the finishing up the corrective care, but also their long-term care, and we have to acquire now our normal listings for the spine since they're now out of the antalgic position. What you see here are 2 x-rays of an acute lower back patient. There is a pre-x-ray on the left when the patient actually is in their acute situation, and the post x-ray on the right after their acute lower back has subsided, their antalgia has also subsided. There's not a lot to see as far as changes on this A to P x-ray, but when we go to the next x-ray, our lateral film, this is where the most dramatic part of the changes are seen. On the left, you see the pre-x-ray. They have a lot of disc degeneration there, so it was not your typical presentation for acute lower back disc, but you could see the antalgic accommodation of the lumbar spine. You see the lower lumbar spine is completely flat. This is the patient guarding, so it's considered more of an anterior type antalgia. If you noticed on the A to P films, we didn't see much antalgia. This patient kind of was a little bit leaned forward and was guarding by flattening out their lumbar lordosis. The post x-ray on the right, you could see how their curve was restored to a pretty nice lumbar lordosis there. But so you can see the difference in the patient's posture. On the left, acute lower back guarded position, loss of lordosis. Afterwards, once the patient had recovered from the acute situation, had regained normal function, that their curve was returned to its normal posture. Now that you've had an opportunity to see the Gonstead protocol for the acute lower back, how a patient presents, how we prepare them for the adjustment, how we adjust them, and how we manage them, how well prepared do you feel with managing a patient with acute lower back? Hopefully it's up at least 1 notch from what you answered at the beginning, and hopefully we're working towards the adequately prepared and well prepared. There's really no way to get you well prepared until you've experienced acute lower back patients, taken them through some protocols, got them through the corrective stage and out of the acute stage, and got them back all the way to wellness stage. That's when you'll probably feel well prepared. You have to experience this a few times to get there. But at least now you have another tool in your arsenal to approach that patient with acute lower back. Just a little wisdom from Gonstead chiropractic system. These are things that I've heard over the years through the doctors I have learned and been training under for Gonstead system. First thing is master your basics first. It's kind of like building a house. You have to have a great solid level foundation so you can build your home above that, so everything is in order once you move forward from the foundation. Also, if any of you have taken a martial arts, as you work your way up through the belts of different colors, some of the martial arts give a philosophical meaning to each of the color of the belts. But pretty much all of them agree with what the philosophy is behind obtaining your black belt. The black belt means basically you have mastered the basics. Now you begin to learn and master your technique. So being a black belt meaning that you have just begun your journey. You have done the basics, you've learned all of those, and now you must work on building and developing your skill. And I kind of consider that the same thing with your chiropractic education is we give you the foundation, you earn your black belt while you're in school, and then for the rest of your chiropractic career, you're building and learning and mastering your skills to be the best you can be. Okay? A little my own philosophy there. Gonstead had a quote, find it, accept it where you find it, fix it, and leave it alone. It's actually one of the quotes on his, it is the quote on his headstone for his grave. It doesn't have the word accepted in it, but that's put in there because don't second guess your findings, don't second guess the nervous system, don't second guess where the subluxation is. Accept it where you find it because you spent a lot of time determining where the subluxation is. You have 5 criteria to help you point in that direction. Don't always chase the symptom. Find the subluxation where it exists, fix it, and leave it alone. Let the body do its thing. Let it heal, let it adapt, let it change, because the body knows how to do that. We just remove the interference. Again, going back to don't over-adjust them. Once the body starts to show improvement, you can start backing off because it's going where you want it to go. It's improving, it's correcting itself, it's adapting, it's changing. Less is better. Gonstead adjusted 1 segment per visit. That is really a huge thing to remember, especially the more complex your patient is, how sick they are when they present, or how severe the problem is. The less you do, the better. That means your patient only has to adapt to 1 input or 1 change in the nervous system at a time. If you believe in the power of the correction of the subluxation, if you're adjusting and correcting or putting impulse into the spine in 3, 4, 5 different areas on the same visit, that requires the body now to adapt, change, and work on 5 different things, 5 different input, 5 different changes, 4 or 3. It's best the more severe the presentation, whether it's a visceral condition, an illness, or a subluxation and musculoskeletal presentation, focus on that one area, that one problem until it gets corrected, and then you can move on to the other areas. As I just mentioned in the acute lower back patient, you can over-adjust the patient. Don't worry about trying to get them fixed with more adjustments. Let the body adapt, let it heal, because there's always tomorrow. You could always let them go that extra day of healing, but you can over-adjust them and send them back to a worse place. Remember to use your x-rays. The x-rays give us a ton of information about that patient, especially about their spine, how we're going to adjust it, where we're going to adjust it, where we're going to contact it, and perhaps what is the best bench or table to use to make that adjustment. Also, as you know, gives us information on contraindications to care or possible immediate referrals. Don't hesitate to ask for help. There's often times that I will get stuck on a case, or another doctor, chiropractor friend of mine reaches a plateau on a case, or has a very challenging case and is just not getting the results that we want. We call each other up and say, hey, can you take a look at this case? Today's technology allows us to share information. We can share x-rays, we can share test results, and allow another set of eyes, another brain to take a look at this case and perhaps give a different perspective to help you move forward with this patient. There have even been cases where another doctor has referred a patient to me because they had reached a plateau in the patient. Again, I got a different perspective, did something a little bit different than they were doing, got the patient over the hump on the road to recovery, and then referred them right back to their doctor to continue their care. So don't hesitate to use others' expertise in your cases. Best thing you could do to learn anything, chiropractic in particular, is start teaching chiropractic to other people. Lower quarter students, be involved in a club, be involved in teaching, whether it's teaching the actual technique, whether it's teaching philosophy, or maybe even teaching or assisting in the classroom or tutoring students. You learn so much more and gain so much perspective on the material that you're learning when you start teaching it. And the last but not least, always be in learning mode. You never know it all. We will never know it all. Always be in learning mode, because that's what being in practice is learning every day from your experience and building on that so you can be a better doctor for your patients tomorrow. Here's the review questions of things you should know about today's lesson. These are things that are very specific about the lesson today, and oftentimes test and quiz questions are taken directly from these, because these are the important things you need to know about the lesson. Have a great day, folks. See you on the next lesson.